before. And I started using monoclonal antibodies for treating Alzheimer's disease in June of 2021. And obviously the drug that was available at that time was the drug aducanumab, which it targets the plaques in the brain, as opposed to lecanemab, which is a drug that just got approved, which targets protofibrils and plaques, and donanemab, which is a drug that's further down the pipeline, which targets the plaques as well. And that's important to kind of keep in the back of your mind as you consider a monoclonal antibody, perhaps for your patients with dementia of the Alzheimer's type, because the epitope that's targeted by the monoclonal antibody may have some impact in terms of efficacy with the drug. So just to go back to my experience, I started with aducanumab again, and the data regarding it was that in patients who were on the 10 milligram dose of the aducanumab in one of the two large trials, there was some benefit on the CDR sum of boxes score of 18 points over 18 months. Patients who were taking the drug at the full dose had a 0.4 a change in CDR compared to patients on placebo over the 18-point scale over 18 months. So you got to keep in mind that that's a very, very small difference between drug and placebo. And also the big issue was that 43 to 45% of patients on aducanumab, particularly in the group that was the ApoE, had one copy of the ApoE4 allele, had a fairly high risk of what's called amyloid-related imaging abnormalities, or ARIA, which includes brain bleeding and brain swelling. So this is problematic because sometimes the brain bleeding and the brain swelling was severe enough to have the patient hospitalized in the ICU and even lead to death. Whereas the majority of the cases of ARIA were relatively mild. So what I decided to do was to titrate up patients from 0 to 10 milligrams per kilogram of the aducanumab based on two factors: their ApoE genotype and also their general medical and cardiovascular status in particular, so that patients who were on a homozygous for the ApoE4 allele, I titrated them up very slowly, so that I have a patient now who is homozygous for the E4 allele, who is only now up to 8 milligrams per kilogram after nearly 2 years. So we've been titrating them up by a milligram every 4 months. And it seems, and I've published on this in the Journal of the American Geriatrics Society, that when you do this kind of slower titration, there is a much reduced risk of ARIA. So that in our patient sample, we had a 0% risk of brain bleeding and brain swelling in the patients who are on aducanumab. Now, the question is, when do you put patients on it? Is it worth putting patients on it? And so I basically made sure that patients had both plaques and tangles. So not just plaques as required by the FDA to put patients on the drug, because I find that sometimes patients who have plaques never go on to develop the tangles. And I have a few patients who have, 30% of the population in their 60s will have plaques, the normal population. So we don't really know what percentage of that group will go on to develop tangles and therefore satisfy the criteria for Alzheimer's disease. So I was wary of putting patients who didn't actually satisfy all clinical criteria on a drug that could be risky and also was expensive. It's a once a month infusion of a drug. So I made sure that my patients were at least had a mini mental status score of at least 20 to 25. The FDA recommends that patients have mild Alzheimer's, so mini mental over 22 or 23 at least. But I would make exceptions for patients who had aphasia and language issues, because those patients tended to have lower scores despite the fact that they didn't really have that much cognitive compromise. And the data seems to be that the majority of the patients stayed stable over time, although there was decline. But my purpose was really not to evaluate efficacy, but really to maintain the patient and prevent significant ARIA-related comorbidity. And the same thing with lecanemab, which got approved this January and became available. I've been using it for patients. And I've been able to, so when lecanemab became available, which is a twice-a-month medication, I intravenous as well, but doesn't really have the kind of level of ARIA, so it's 22% as opposed to 43%. I put patients, switched patients from aducanumab to lecanemab because basically I would check their amyloid scans, and if they had no amyloid, then there was no reason to switch them to the lecanemab. But if they continue to have amyloid on aducanumab, then I switched them to lecanemab. So I have a bunch of patients now on lecanemab. Again, the titration there, I went a little bit slower. Lecanemab does not have a titration. It's 10 milligrams per kilogram. You start that off right away. But I generally start patients on 6 milligrams or 5 milligrams per kilogram and then titrate them up to the 10 milligrams per kilogram. And I think, again, we've not had any side effects so far, but our sample size here is under 10 patients, so we don't have a larger sample size. With the aducanumab, I think we're now up to 30 patients. And in these 30 patients, subsequent to my publication, we now have 2 patients with mild small microhemorrhages and 1 patient who has had brain swelling, who have all continued to be on the medication and did not have any clinical signs or symptoms. I believe these drugs are game changers, particularly in preventing the development of Alzheimer's in patients who are at risk, although the data there is not available at this time. But I do believe, because amyloid seems to be the first biomarker that is the harbinger of Alzheimer's disease in a patient who's high risk, who's homozygous, let's say for the ApoE4 with a strong family history, who has a significant amount of amyloid, it may be something you want to consider. And certainly for patients with mild Alzheimer's, I believe it's a good adjunctive treatment, provided that you monitor risk factors.